Before we begin, please note that the information provided in this video is for educational and informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. You get a bill in the mail. It's for a routine checkup, maybe an ER visit for your kid's sprained ankle. You tear open the envelope, your eyes scan past the jargon, the CPT codes, the service descriptions, and land on the final number. And your stomach drops. It's a figure that makes no sense. A number that feels completely disconnected from the service you received. $3,000 for a few stitches. $500 for a 15-minute consultation. You stare at it, a mix of anger and confusion boiling up inside. How is this possible? How can the price be so high? And why is it so confusing? If that feeling is familiar, you are not alone. That single piece of paper in your hand isn't just a bill. It's the end result of 100 years of political deals, corporate lobbying, and historical accidents that have created the most expensive, most complicated healthcare system in the developed world. And here's the most important thing you need to understand. None of this is an accident. The confusion is by design. The high costs are a feature, not a bug. Your frustration is a direct consequence of a system that was never truly built for you, the patient. But what if you could understand it? What if you could finally see behind the curtain and grasp why things are the way they are? That's the promise of this series. We are going to demystify American healthcare. We're going to give you the blueprint. By the end, you will understand why your health insurance is tied to your job. You'll know why the exact same MRI costs $500 at one clinic and $5,000 at the hospital across the street. You will finally understand the difference between a deductible, a copay, and coinsurance, and how to use that knowledge to save yourself real money. We are going to transform you from a confused patient into an empowered, informed consumer who can navigate this broken system with confidence. To do that, we have to start at the beginning. Not with the latest political debate, but with a question that almost every American has but few can answer. Why on earth is my health insurance tied to my job in the first place? No other developed country does it this way. So how did we end up with this bizarre, uniquely American system? The answer, incredibly, has nothing to do with health. It has to do with World War II. Picture the United States in the early 1940s. The country is in full-on war mode. Millions of men are overseas, and factories on the home front are operating around the clock, churning out planes, tanks, and ships. This created a massive labor shortage. With so many jobs available and not enough workers to fill them, companies started competing for the best talent. And how do you compete for workers? You offer them more money. Wages started to skyrocket. The government, under President Franklin D. Roosevelt, saw a huge problem. This rapid wage inflation could cripple the war economy. So, in 1942, they did something drastic. They passed the Stabilization Act. This law effectively froze all wages. A company was legally forbidden from offering a higher salary to poach an employee from another factory. Now, put yourself in the shoes of a factory owner. You desperately need more workers to meet your production quotas, but your most powerful tool, money, has just been taken away. You can't offer a bigger paycheck. So what do? You get creative. You start offering other things. Things that weren't considered wages. Things like paid time off, pensions, and, you guessed it, health insurance. At the time, health insurance was a tiny niche product. Most people just paid their doctor a few dollars out of pocket for a visit. But as a workplace perk, it was brilliant. It was something new, something valuable that companies could offer to attract workers without technically breaking the law on wage freezes. Then came the final crucial piece of the puzzle. The Internal Revenue Service, the IRS, made a fateful decision. They ruled that these new employer-paid health insurance benefits were not subject to income tax. And with that, the floodgates opened. Suddenly, a dollar spent on health insurance by your employer was worth more than a dollar in your paycheck, because you didn't have to pay taxes on it. It was essentially a tax-free raise. For employers, it was a tax-deductible business expense. For workers, it was a tax-free benefit. It was a win-win, and the practice exploded in popularity. Unions began demanding generous health plans in their contract negotiations. Companies started competing to offer the best, most comprehensive coverage. And so, a temporary wartime measure, a clever workaround to a wage freeze, accidentally became the foundation of the entire American healthcare system for the next 80 years. It was never debated in Congress as the best way to insure a nation. It was never designed by health experts. It was an improvised solution to a wartime labor problem that became permanent. This single historical accident has profound consequences that you feel every single day. It's the reason you experience the job lock phenomenon, that fear of leaving a job you dislike, because you can't bear the thought of losing your health coverage. It's why losing your job can trigger a full-blown life crisis, as not only your income but your entire family's access to medical care vanishes overnight. It's why entrepreneurs and small business owners face a massive disadvantage, forced to buy insurance on the expensive individual market, while large corporations can negotiate better rates for their employees. But the most significant consequence of this employer-based system was the creation of what experts call a third-party payer model. And understanding this concept is the absolute key to understanding everything else about the system's broken economics. Before this system, healthcare was simple. You, the patient, paid the doctor directly. There were two parties in the transaction: the buyer, you, and the seller, the doctor. You were the customer. You could ask about the price. You could shop around. You had a direct financial relationship with your care. The employer-sponsor system shattered that relationship. It inserted a giant middleman, the insurance company, right between you and your doctor. Now, you don't pay the doctor directly. You pay your premium to the insurance company. The doctor performs a service, and then they send a bill to the insurance company. The insurance company pays the doctor. You, the patient, are no longer the one paying the bill. You become a bystander in the financial transaction for your own health care. Think about what this does to prices. When you go to a restaurant, you look at the menu, you see the prices, and you make a decision. You are sensitive to the cost because the money is coming directly out of your pocket. But what if your company gave you a meal insurance card? And this card meant you only had to pay a flat $20 copay, no matter what you ordered, whether it was a side salad or a giant lobster. What would you do? You'd probably order the lobster every time. Why not? You aren't paying the real price. When you are disconnected from the true cost of something, you consume more of it, and you become completely insensitive to the price. This is exactly what happened in American healthcare. For decades, patients didn't ask, "How much does this cost?" They asked, "Is it covered?" As long as the insurance company was footing the bulk of the bill, the actual price became irrelevant. And for hospitals and doctors, this was a golden age. Their real customer was no longer the price-conscious patient, but a massive, deep-pocketed insurance company. They could start charging higher and higher prices because the patient wasn't complaining, and the insurance company in the early days would simply pay. This created a vicious cycle. More demand and zero price sensitivity sent costs spiraling upwards, year after year, decade after decade. This single accidental change, tying health insurance to jobs during World War II, created a system where the normal rules of economics simply don't apply. It divorced the consumer from the price, leading to an explosion in costs that continues to this day. That outrageous bill you got in the mail? Its roots trace directly back to that factory owner in 1943, trying to find a clever way to hire a welder. So, this accidental system was now in place. Millions of Americans were getting their health insurance through their jobs. But this created a new massive problem. What about the people who couldn't work? The elderly, the poor, the unemployed? In this new employer-centric system, they were left completely vulnerable with no safety net at all. The country was now divided into the insured and the uninsured. And as medical technology advanced and costs continued to rise, being uninsured was becoming more and more dangerous. This set the stage for the next great battle in American healthcare, a political war that would create the two biggest government health programs in our history and forever change the relationship between the government, its citizens, and their health. The end of World War II brought a wave of optimism across America. GIs were coming home, the economy was roaring to life, and the nation felt it could achieve anything. For President Harry Truman, anything included solving the healthcare crisis once and for all. He saw a country where a single illness could bankrupt a family, and he believed the government had a moral duty to fix it. In 1945, just months after taking office, Truman did something incredibly bold. He went before Congress and proposed a national health insurance program for every single American, funded by a payroll tax. It was, in essence, Social Security for healthcare. He argued that a healthy population was a productive population, a cornerstone of national security. To him, it was common sense. But he had just kicked a hornet's nest. And the Hornets were led by the American Medical Association, the AMA. The AMA, representing the nation's doctors, saw Truman's plan not as a safety net, but as a government takeover. They launched one of the most effective public relations campaigns in American history. They didn't just argue against the policy, they gave it a terrifying new name: socialized medicine. Remember the context. This was the dawn of the Cold War. The fear of communism was palpable. The AMA brilliantly linked government-run healthcare to Soviet-style totalitarianism. They ran ads in thousands of newspapers and magazines. One famous ad featured a kindly, old-fashioned doctor next to a picture of Uncle Sam holding a stethoscope, with the caption, "Keep politics out of this picture." They hired a firm called Campaigns Incorporated, which had perfected the art of political warfare in California. Their strategy was simple: paint Truman's plan as a slippery slope to a complete government-controlled society. They warned that you would lose the right to choose your own doctor, that a government bureaucrat in Washington would be standing between you and your physician, making life or death decisions. They distributed pamphlets in doctors' offices, turning every waiting room into a front line in this political war. And it worked. The socialized medicine label stuck. Public support cratered. Congress, spooked by the powerful doctor lobby and the potent fear of communism, backed away. Truman's grand vision for universal health care was dead on arrival. This failure was a massive turning point. It established the political playbook for opposing healthcare reform for the next 70 years. Brand it as a foreign socialist takeover of American freedom. But the problem didn't go away. People were still going broke from medical bills. So, the country stumbled into a different solution almost by accident. During World War II, the government had imposed strict wage freezes to control inflation. Companies, desperate to attract workers, couldn't offer more money, so they got creative. They started offering better benefits, including health insurance. Then, in 1954, under a very different president, Republican Dwight D. Eisenhower, the government made a seemingly small but monumental decision. The Internal Revenue Service officially ruled that the money companies spent on employee health insurance would not be taxed. Think about what this meant. If your boss gave you a $100 raise, you had to pay income tax on it. But if your boss spent that same $100 on a health plan for you, it was completely tax-free. It was like getting a raise that the government couldn't touch. This created a massive incentive for both companies and workers to favor health insurance as part of a compensation package. This decision, the employer-sponsored insurance tax deduction, is the single biggest reason why most Americans today get their health insurance through their job. It wasn't a grand plan designed by experts. It was a historical accident, a wartime workaround that was later locked into the tax code. Eisenhower, a pragmatist, saw this as the perfect American solution. It wasn't socialized medicine. It was private. It was based on employment. It strengthened the free market. For the booming working middle class of the 1950s, this new system seemed to work just fine. Millions of Americans gained coverage. A vast private insurance industry blossomed. The problem seemed solved. But it wasn't. This new system created a nation of healthcare, haves and have-nots. If you were a union auto worker in Detroit or an executive in New York, you were set. You had good, stable coverage. But what if you weren't? What if you were a farmer? A small business owner? Unemployed? Or most critically, what if you were retired? This was the gaping, tragic hole in the employer-based system. The moment you stopped working, you lost your health insurance. And this happened at the exact moment in your life when you were most likely to need it. For America's senior citizens, the 1950s and early 60s were a healthcare nightmare. They had the highest medical needs and the lowest incomes. Private insurance companies saw them as a terrible risk. They would either charge seniors astronomical premiums that few could afford, or they would simply deny them coverage outright for having pre-existing conditions. Stories began to fill the newspapers about elderly couples selling their homes to pay for a hospital stay, of seniors choosing between food and medicine. The problem became so acute it could no longer be ignored. The private, employer-based system had failed an entire generation of Americans at their most vulnerable. Into this crisis stepped a charismatic young senator from Massachusetts, John F. Kennedy. During his 1960 presidential campaign, he made healthcare for the elderly a central issue. He framed it not as an economic debate, but as a moral one, a matter of dignity. He argued that after a lifetime of working and contributing to society, our seniors deserve to live their final years free from the fear of medical bankruptcy. Kennedy's proposal was more modest than Truman's. He wasn't pushing for universal care for everyone. He was targeting the one group that was clearly, undeniably left behind. His plan, which he called Medicare, would provide hospital insurance for everyone over 65, and it would be funded just like Social Security, through payroll taxes. The AMA, seeing this as the ghost of Truman's plan, geared up for another war. They dusted off the old playbook and launched Operation Coffee Cup. They enlisted doctors' wives across the country to host gatherings in their homes, where they would play a recording of a well-known actor warning about the evils of socialized medicine. That actor was Ronald Reagan. In the recording, Reagan warned with grave sincerity that if Medicare passed, "You and I are going to spend our sunset years telling our children and our children's children what it once was like in America when men were free." The AMA spent millions, more than any political campaign of that era, to defeat Kennedy's plan. And for a while it seemed to be working. Their powerful lobbying efforts stalled the bill in Congress. The political gridlock was intense. President Kennedy had the bully pulpit, but the AMA had an iron grip on key congressional committees. The fight was a stalemate. The nation's seniors were caught in the middle, their hopes hanging by a thread. Then, on November 22, 1963, everything changed. The assassination of President Kennedy was a national trauma, but it also fundamentally altered the political landscape. His successor, Vice President Lyndon B. Johnson, was a man of towering ambition and legendary political skill. He had spent decades in Congress and knew how to bend it to his will. As the nation mourned, Johnson saw a unique opportunity. He could honor the fallen president's legacy by passing the ambitious agenda Kennedy had championed. And at the very top of that list was the unfinished business of providing health care for the elderly. Johnson, the master legislator, armed with a powerful mandate born from tragedy and a landslide election victory in 1964, was about to take on the AMA in a battle that would dwarf everything that had come before. This time the outcome would be very, very different. Lyndon B. Johnson was not a persuader. He was a force of nature, a towering Texan who understood the levers of power in a way few ever have. He had spent decades in the House and Senate, mastering its arcane rules, learning every member's weaknesses, their ambitions, their secrets. He knew who needed a dam in their district, who had a family member needing a federal appointment, and who would fold under the sheer physical intimidation of his famous Johnson treatment, the president leaning his 6'4" frame into a legislator's personal space, his voice a mix of gravelly threat and sweet-talking promise, until there will simply evaporated. And in 1965, he had something no president since Franklin Roosevelt had possessed: an overwhelming filibuster-proof Democratic majority in both houses of Congress. The 1964 election wasn't just a victory, it was a political realignment. Johnson saw this as a once-in-a-generation opportunity, a window to build what he called the Great Society. And at the heart of that vision was finishing the fight for healthcare that had consumed and defeated his predecessors. The American Medical Association saw him coming. They knew this was the final boss battle, and they unleashed the most expensive lobbying and public relations campaign in American history up to that point. They revived their old playbook, screaming socialized medicine from the rooftops. But this time they had a new charismatic spokesman, a Hollywood actor who was becoming a rising star in conservative politics. His name was Ronald Reagan. The AMA launched a campaign called Operation Coffee Cup. The idea was simple and brilliant. They encouraged doctors' wives to host coffee gatherings in their homes, where they would play a recording of Reagan. On this record, Reagan's calm, reassuring voice warned of a looming threat. He wasn't frantic. He was concerned. He warned that Medicare was a slippery slope. He said, and I quote, "If you and I don't do this, then one of these days we are going to spend our sunset years telling our children, and our children's children, what it once was like in America when men were free." He argued that if the government got into healthcare, it would eventually control every aspect of American life. The campaign was a sensation. Millions of Americans heard this message in their neighbors' living rooms. The AMA's message was clear. This bill wasn't about helping grandma. It was about government intrusion, the first step towards a socialist state. But Johnson had a crucial advantage. The narrative had shifted. The AMA was no longer fighting a vague concept of national health insurance. They were fighting a specific proposal to help the elderly, and that was a much, much harder fight to win. Who could be against helping their own parents and grandparents, who were often living in poverty precisely because one illness could wipe out their life savings? Johnson and his allies hammered this message home. This wasn't socialism, it was about dignity for seniors. The true battlefield, however, wasn't in America's living rooms. It was in a single powerful committee in the House of Representatives, the Ways and Means Committee, and its chairman was a man named Wilbur Mills. For years, Mills, a conservative Democrat from Arkansas, had been the graveyard of all health insurance legislation. Nothing got to the House floor without his approval, and he had never approved. He was skeptical of the cost, the bureaucracy, and the federal overreach. Johnson knew he couldn't just roll over Mills. He had to be converted. The White House launched a full-court press. They sent study after study to Mills's office, showing the dire state of healthcare for the elderly. They organized town halls in his district. They had his most trusted colleagues and friends whisper in his ear. Slowly, methodically, they chipped away at his opposition. Mills, a shrewd politician, could also read the election results. He saw the massive Democratic majority and knew the tide was turning. He didn't want to be the man who stood in the way of history, only to be swept aside by it. He signaled he was ready to deal. And it was here that the legislative magic happened. The moment that created the system we know today. The Johnson administration had its bill, known as Medicare, which would use Social Security funds to pay for hospital care for seniors. Let's call this Layer 1. The Republicans, not wanting to seem heartless, had their own, less ambitious proposal for voluntary insurance to cover doctors' visits. Let's call this Layer 2. And a third proposal, backed by liberal Democrats, aimed to expand medical assistance to the poor, not just the elderly. Layer 3. The old way of doing things would have been to fight it out, with one bill winning and the others losing. But Wilbur Mills, the former obstructionist, now turned architect, did something no one expected. He took all three proposals and baked them together into one giant three-layer cake of legislation. Layer 1 became Medicare Part A, mandatory hospital insurance for seniors, funded through payroll taxes. This was the original White House plan. Layer 2 became Medicare Part B, voluntary, subsidized insurance to cover doctor bills and other outpatient services. This was the Republican plan, now incorporated into the whole. And Layer 3, almost as an afterthought, became Medicaid, a federal-state partnership to provide health care for the poor, the blind, and disabled people receiving public assistance. It was a stroke of political genius. By incorporating his opponent's ideas, Mills didn't just defeat them, he absorbed them. Republicans couldn't vote against their own proposal. The AMA, which had supported a version of the voluntary plan, was now completely outmaneuvered. Johnson, seeing the brilliance of the move, threw his full support behind the three-layer cake. The bill flew through the Ways and Means Committee, passed both the House and the Senate by enormous margins, and landed on the president's desk. On July 30, 1965, Lyndon Johnson boarded Air Force One. But he didn't sign the bill at the White House. He flew to Independence, Missouri. He walked into the Truman Presidential Library, and there, sitting at a table waiting for him, was a frail 81-year-old Harry S. Truman, the man who had started this fight 20 years earlier. With Truman sitting beside him, Johnson signed the Social Security Amendments of 1965 into law, creating Medicare and Medicaid. He then turned and gave the very first Medicare card to Harry Truman, and the second to his wife, Bess. "You were the real daddy of Medicare," Johnson told him. The long, bitter war was finally over. The impact was immediate and profound. Within a year, 19 million Americans were enrolled in Medicare. For the first time, a major illness didn't automatically mean financial ruin for the elderly. But there was another, equally massive consequence that nobody talks about. Tucked away in the Civil Rights Act of 1964 was a provision that said no federal funds could go to any institution that practiced racial segregation. At the time, thousands of hospitals, especially in the South, were completely segregated. They had separate wings, separate waiting rooms, separate blood supplies. Black doctors were often barred from practicing. When Medicare was passed, the government suddenly had a giant financial hammer. Federal officials fanned out across the country and delivered a simple message to these hospitals: desegregate, or you will not get a single dollar of Medicare money. Faced with financial extinction, nearly every hospital in America complied within a matter of months. In one fell swoop, a health policy law became one of the most powerful tools for desegregation in American history. Seemed like a total victory, a problem identified, a political war won, and millions of lives changed for the better. But in solving one crisis, Johnson and Mills had unknowingly planted the seeds of the next one. The new system had a fundamental design flaw, an economic engine with no brakes. Both Medicare and the private employer-sponsored plans it was modeled on were built on a fee-for-service model. That meant that hospitals and doctors got paid for every single test, every procedure, every service they provided. Think about it. The more they did, the more they got paid. There was no incentive for efficiency. There was, in fact, a powerful incentive for the opposite. If a new, more expensive technology came along, there was every reason to use it. If a patient could be given 5 tests instead of 2, why not? The patient wasn't paying the full cost, and the insurer, whether the government or a private company, was legally obligated to foot the bill. Nobody was asking, is this procedure truly necessary? Is there a more cost-effective way? A silent, self-perpetuating cash machine had just been switched on at the heart of the American healthcare system, and the costs, which had been rising steadily before, were about to go into hyperdrive, creating a whole new crisis that would dominate the next 50 years of health policy. To understand what happened next, you have to understand the fundamental incentive built into the system. Before Medicare, and supercharged by it, American medicine largely ran on what's called a fee-for-service model. Sounds simple, and it is. A doctor performs a service, an office visit, a blood test, a surgery, and the insurance company or now the government pays a fee for that service. The more services you perform, the more fees you collect. The more complex and expensive the service, the bigger the fee. Now, in a world with limited technology and a shared sense of professional restraint, this system can sort of work. But in the 1970s, that world was vanishing. Medical technology was exploding. We were developing CT scanners, MRIs, new heart bypass techniques, and a whole arsenal of powerful, expensive new drugs. For doctors and hospitals, these weren't just medical miracles, they were revenue streams. Under a fee-for-service system, there was no financial incentive for a doctor to ask, is this 10th test really necessary? In fact, the incentive was the exact opposite. Doing the test generated a fee. Not doing it generated nothing. The system wasn't paying for health outcomes. It was paying for activity. It was like giving a mechanic a blank check and telling him to find things to fix on your car. You're probably going to end up with a lot of new parts. And so, the costs began to spiral. Hospitals, competing for the best doctors who brought in the best insured patients, entered what became known as a medical arms race. If the hospital across town got a shiny new MRI machine, you had to get one too, even if the community only needed one. Both hospitals then had to run as many scans as possible to pay for these multi-million-dollar machines. The result was a massive duplication of expensive services and technology, the cost of which was passed directly on to patients, employers, and the government in the form of higher premiums and taxes. By the early 1970s, President Richard Nixon, a Republican, was looking at the budget projections for Medicare and Medicaid and seeing a fiscal catastrophe on the horizon. The cost of healthcare was growing at a terrifying rate, threatening to swallow the entire federal budget. Something had to be done to slam on the brakes. The solution, championed by a health policy expert named Paul Elwood and embraced by the Nixon administration, was a radical new idea. The Health Maintenance Organization, or HMO. If fee-for-service was a blank check, the HMO was a budget. The concept was to completely flip the financial incentive. Instead of paying doctors and hospitals for every little thing they did, an HMO would be paid a flat fee per person per year. This is called capitation. Let's say an HMO gets paid $10,000 to cover you for the year. If your medical care only costs $2,000, the HMO keeps the remaining $8,000 as profit. But if you have a major health crisis and your care costs $50,000, the HMO has to eat that $40,000 loss. Suddenly, the entire incentive structure is reversed. The HMO now makes money by keeping you healthy. They are incentivized to invest in preventive care, vaccines, checkups, cancer screenings, because it's far cheaper to prevent a disease than to treat it. They are incentivized to use the most cost-effective treatments, to avoid unnecessary tests, and to get you out of the expensive hospital as quickly as possible. This new model was called managed care, and on paper, it sounded like the perfect antidote to the excesses of fee-for-service. The HMO Act of 1973 was passed with bipartisan support, providing federal funds to encourage the creation of these new organizations. But as HMOs grew in power and popularity through the 1980s, a massive public backlash began to build. The very mechanisms that made HMOs effective at controlling costs were seen by patients as cruel and restrictive. The gatekeeper, your primary care physician who had to approve any visit to a specialist, felt like a barrier to care. The requirement to use only doctors in-network felt like a loss of freedom, and the stories began to multiply. Stories of HMOs denying life-saving treatments to save money, of accountants overriding the decisions of doctors, of people feeling trapped in a system that valued profits over their health. The public perception shifted from HMOs being a smart way to manage care to a heartless system that rationed care. While the battle between fee-for-service and managed care raged, the underlying foundation of the system, employer-sponsored insurance, was showing deep cracks. What happened if you lost your job? In the American system, it meant you and your entire family instantly lost your health insurance, often at the very moment you could least afford to be without it. It was a moment of extreme vulnerability. In 1985, Congress passed a law to try and patch this gaping hole. It's called COBRA. COBRA mandates that companies of a certain size must allow you to continue your health coverage for a limited time, usually 18 months, after you leave your job. It sounds great, but there's a catch, and it's a big one. You now have to pay the entire premium yourself, including the large portion your employer was previously subsidizing, plus an administrative fee. For most newly unemployed people, paying a premium of $1,000, $2,000, or even $3,000 a month is simply impossible. So, COBRA became a lifeline for the few who could afford it, and a cruel joke for the many who couldn't. It was another patch on a system that was fundamentally unstable. Then, just a year later in 1986, another critical law was passed, one that profoundly shapes every hospital visit to this day. It's called EMTLA, the Emergency Medical Treatment and Active Labor Act. Before EMTLA, it was common practice for private hospitals to engage in patient dumping. If a person showed up in their emergency room without insurance or the ability to pay, the hospital would often put them in an ambulance and dump them at the nearest public or charity hospital. It was brutal. EMTLA made that illegal. It mandated that any hospital that accepts Medicare, which is virtually all of them, must provide a medical screening to anyone seeking emergency treatment and must stabilize their condition, regardless of their insurance status or ability to pay. This was a landmark piece of civil rights legislation, establishing a legal right to emergency care. But it had a colossal, unintended financial consequence. It created an unfunded mandate. The government ordered hospitals to provide this care, but it didn't provide a dedicated way to pay for it. So what happens? The hospitals provide the care, and they eat the cost. But of course they don't really eat it. They shift it. The cost of caring for the uninsured in the most expensive setting possible, the emergency room, gets baked into the prices charged to everyone else. It's a hidden tax. Your insurance premiums go up, your copays go up, the price of a hospital stay goes up, all to cover the billions of dollars in uncompensated care that EMTLA mandates. The ER effectively became the nation's primary care doctor for the poor and uninsured, the most inefficient and expensive way imaginable to deliver basic health care. By the dawn of the 1990s, the American healthcare system was a paradox of warring incentives. We had the fee-for-service doctors and hospitals, driven to do more and charge more by an explosion in technology. We had the managed care HMOs, driven to do less and deny more to protect their bottom line. We had a patchwork system of laws like COBRA and EMTLA, noble in their intent, but which inadvertently added more cost and complexity to an already overburdened structure. Costs were higher than ever, more people were uninsured than ever, and everyone, patients, doctors, employers, and insurers, was angry. The system was straining at the seams, and the country was about to embark on its most ambitious and politically explosive attempt at reform yet. The year is 2008. The American economy is in freefall. Lehman Brothers has collapsed, the stock market is plummeting, and millions are losing their jobs, their homes, and their savings. And with their jobs went their health insurance. This economic catastrophe poured gasoline on the fire of the healthcare crisis. The problem was no longer just a debate for policy experts in Washington. It was a kitchen table emergency for families across the country. And into this firestorm stepped a presidential candidate named Barack Obama, who made a promise that had become a political graveyard for his predecessors: comprehensive healthcare reform. It wasn't just a campaign plank. It was the centerpiece of his vision for the country. When he won, he had a mandate, a Democratic majority in both the House and the Senate, and a sense of historic urgency. But the ghosts of past failures loomed large. President Clinton had tried and failed spectacularly in 1993. The lesson learned was that you couldn't just drop a 1,000-page bill on Congress and expect it to pass. This time, the White House decided on a different strategy. Let Congress write the bill. The goal was to build a coalition to give lawmakers ownership of the final product. But this strategy opened the door to a year of brutal, knockdown, drag-out political warfare that would define the next decade of American politics. To understand the fight, you have to understand what they were fighting to fix. The problems were deeply personal. First, there was the issue of pre-existing conditions. Before 2010, if you had a health condition, anything from diabetes to cancer, or even just high blood pressure or asthma you had as a kid, an insurance company in the individual market could simply refuse to sell you a policy. Or they could sell you one but exclude any coverage related to that condition. It was a simple, brutal calculation. Insurers were for-profit businesses, and sick people were expensive, so they avoided them. This created a nightmare scenario where the people who needed insurance the most were the very people who couldn't get it. Then there were lifetime and annual caps. Imagine you get a devastating diagnosis like a rare form of cancer. The treatment is expensive, but you have good insurance. But then, halfway through your treatment, you get a letter. You've hit your lifetime maximum, say $1 million. From that point on, your insurance pays nothing. You're on your own. People were losing their homes, their life savings, and their lives because their insurance had an expiration date they never knew existed. And of course, there was the staggering number of uninsured, nearly 50 million Americans. These weren't just the unemployed. Many were the working poor, people patching together part-time jobs or working for small businesses that simply couldn't afford to offer health benefits. They were one car accident, one bad fall, one sudden illness away from complete financial ruin. When they did get sick, they often waited until it was an emergency, then showed up at the ER, the most expensive place to get care. The hospital was legally obligated to treat them, but those costs didn't just disappear. They were passed on to everyone else in the form of higher hospital bills and, you guessed it, higher insurance premiums for all of us. This was the hidden tax that everyone with insurance was already paying. The proposed solution, which would eventually become the Patient Protection and Affordable Care Act, or ACA, was built on a concept often described as a three-legged stool. It was an idea borrowed from a similar successful reform passed in Massachusetts under a Republican governor, Mitt Romney. For the system to be stable, all three legs had to be there. Kick one out and the whole thing collapses. The first leg was insurance market regulation. This was the most popular part. It said insurance companies could no longer deny coverage or charge you more based on your health history. No more pre-existing condition exclusions. No more lifetime caps. It also required all plans to cover a set of essential health benefits, like maternity care, mental health services, and prescription drugs. This was a fundamental shift, treating healthcare less like a product you buy at a store and more like a utility everyone should have access to. But this first leg creates a huge problem. If you tell insurers they have to accept everyone but you don't change anything else, what happens? Healthy people might decide to wait until they get sick to buy insurance. Why pay premiums every month if you can just sign up the moment you need a major surgery? The result would be an insurance pool filled with only sick, expensive people. Premiums would skyrocket, more healthy people would drop their plans, and the market would enter a death spiral. It would collapse. That's where the second leg comes in, the individual mandate. This was by far the most controversial part of the law. It required most Americans to have health insurance or pay a penalty on their taxes. The idea was to keep the insurance pool balanced. By requiring everyone, both healthy and sick, to be in the system, the costs could be spread out, keeping premiums more affordable for everyone. It was the trade-off. In exchange for forcing insurers to cover the sick, the government was forcing everyone to buy their product. To its supporters, it was a necessary mechanism for a functioning market. To its opponents, it was an unprecedented and unconstitutional overreach of government power. But even with the mandate, millions of people still couldn't afford insurance. That's the third leg of the stool, subsidies. The law provided tax credits to help people with low and moderate incomes buy insurance on their own. The less you made, the more help you got. This was designed to make the mandate fair. The government wasn't just ordering you to buy a product, it was helping you pay for it. The law also dramatically expanded Medicaid, the government program for the very poor, to cover millions more low-income adults who previously didn't qualify. These three legs, regulations, the mandate, and subsidies, were the core of the ACA. Other popular pieces were added on. Young adults could now stay on their parents' insurance plans until age 26. A new marketplace website, healthcare.gov, was created to be a one-stop shop where people could compare plans and sign up for coverage. But as these ideas were being debated in Congress throughout 2009, the political environment turned toxic. Town hall meetings held by members of Congress that summer became screaming matches. The debate was no longer about policy details, it was about fear. Opponents of the bill warned of a government takeover of healthcare. The most potent and enduring accusation was the claim of death panels. The idea that the government would create bureaucratic boards to decide who would live and who would die to save money. It was a complete fabrication, based on a provision that would have allowed Medicare to pay doctors for voluntary end-of-life counseling, but it caught fire. The narrative was set. This wasn't just a bill. It was a threat to American freedom. The legislative process became a marathon of backroom deals and procedural gymnastics. In the Senate, Democrats needed 60 votes to overcome a Republican filibuster. They got exactly 60 on Christmas Eve of 2009, passing their version of the bill. But before the House and Senate could reconcile their different versions, a special election in Massachusetts to fill the seat of the late Ted Kennedy shocked the political world. A Republican, Scott Brown, won, promising to be the 41st vote against the bill, effectively killing it. Seemed that, once again, healthcare reform was dead. But the Democrats found one last, desperate path forward. A complex and rarely used legislative maneuver called budget reconciliation. It would allow the final tweaks to the bill to pass the Senate with just 51 votes. In March 2010, after more than a year of brutal debate, the House of Representatives passed the Senate's original bill, sending it to the president's desk. A second bill with the fixes was then passed through reconciliation. It was done. Against all odds, the most significant piece of social legislation in decades had become law. But the stroke of the president's pen wasn't an ending. It was the beginning of a whole new war. The political victory was monumental, but in the American system, a law passed by Congress and signed by the president is only the first round. The next battle would be fought not in the halls of the Capitol, but in the marble chambers of the judiciary. The opposition, having lost the legislative fight, immediately pivoted to a new strategy: to have the entire law declared unconstitutional. Within minutes of the bill being signed, the first lawsuit was filed. Then another, and another. In the end, 26 different states would join a single massive legal challenge against the federal government. It was a legal earthquake, and the primary fault line was a single four-word phrase: the individual mandate. This was the core of the law, the engine that made the whole system work. The requirement that nearly every American obtain health insurance or pay a penalty. The logic was simple. If insurance companies had to cover people with pre-existing conditions, they couldn't survive if healthy people waited until they got sick to buy a policy. That would be like letting people buy car insurance after they crash. The system would collapse. The mandate brought healthy people into the insurance pool, spreading the risk and keeping costs down for everyone. It was an elegant, market-based solution. But was it constitutional? The challengers argued with incredible force that it was not. Their case rested on a fundamental question about the limits of federal power. Congress, they said, has the power to regulate interstate commerce, the buying and selling of goods and services across state lines. But the individual mandate, they argued, wasn't regulating commerce. It was compelling it. It was forcing people who had chosen to do nothing, to not buy a product, into an economic activity against their will. This, they claimed, was a breathtaking overreach of government authority. If the government can force you to buy health insurance, what can't it force you to do? Can it force you to buy a General Motors car to prop up the auto industry? Can it force you to buy broccoli to promote healthy eating? The broccoli argument, as absurd as it sounded, became a powerful and memorable symbol of the opposition's fears. A slippery slope toward a government with no limits on its power over individual lives. The government's defense was just as powerful. They argued that healthcare is a unique market. It's not a question of if you will use it, but when. Everyone at some point needs medical care. And when someone without insurance gets sick or injured and shows up at an emergency room, they receive that care by law. They don't get turned away. But that care isn't free. The cost of their treatment, which can be astronomical, gets passed on to everyone else in the form of higher hospital bills and higher insurance premiums. This cost shifting, the government argued, was a multi-billion-dollar problem that absolutely constituted interstate commerce. The uninsured weren't inactive. By choosing not to buy insurance, they were actively making a decision about how they would pay for future care. And that decision had massive economic consequences for the entire country. The mandate wasn't forcing people into commerce, it was regulating how they participated in a market they were already in, whether they liked it or not. The lawsuits worked their way through the federal court system, and the nation watched as different judges came to wildly different conclusions. Some lower courts struck down the mandate, others upheld it. The split decisions made one thing inevitable. This was a question that only the Supreme Court could answer. In the spring of 2012, the case, now known as National Federation of Independent Business versus Sebelius, reached the highest court in the land. The stakes were almost impossibly high. The fate of a law affecting 1/6 of the U.S. economy and the health care of tens of millions of people now rested in the hands of 9 justices. The oral arguments were the most anticipated in a generation. For 3 days, the lawyers for both sides argued their case in a tense, high-wire act of legal reasoning. The focus was on the 2 crucial swing votes on the court: Justice Anthony Kennedy and especially the Chief Justice John Roberts. Every question they asked, every hypothetical they posed, was dissected by legal scholars and journalists for clues about which way they were leaning. And for supporters of the law, the signs were not good. The justices, particularly the conservatives, hammered the government's lawyer on the Commerce Clause argument. They seemed deeply, profoundly skeptical of the idea that the federal government could force someone to buy a product. The broccoli hypothetical came up again and again. The government's lawyer seemed to be struggling to find a limiting principle, a clear line that would allow the health insurance mandate, but prevent the government from ordering citizens to buy other things. As the arguments progressed, a consensus began to form among the expert court watchers. The mandate was going down. The core of the law was about to be ripped out, and the entire structure would likely collapse with it. It looked like the president's signature achievement was about to be erased by the Supreme Court. But the government had a backup plan, a second, less publicized argument. It was something of a legal Hail Mary. They argued that even if the mandate wasn't a constitutional use of the commerce power, it could be viewed another way. That penalty you had to pay for not having insurance? Don't think of it as a penalty. Think of it as a tax. The law wasn't commanding you to buy insurance. It was simply giving you a choice: buy insurance or pay a little extra in your taxes. And throughout American history, there is one power of Congress that is almost unlimited: its power to tax. This argument had been downplayed by the administration for political reasons. Nobody wants to be seen as raising taxes. And during the oral arguments, it seemed to get very little traction. The justices barely focused on it. It was seen as the weaker, less plausible defense, a legal afterthought. But in the quiet, secret deliberations of the Supreme Court, that afterthought was about to become the single most important legal argument of the decade. As the world waited for the decision, no one knew that the entire law was hanging by this one slender thread. Inside the marble fortress of the Supreme Court, the 9 justices met in their private, soundproof conference room. No clerks, no aides, no one. Just 9 of the most powerful legal minds in the country, about to decide the fate of a law that touched nearly every single American. The air was thick with history and tension. And when the initial secret vote was taken on the constitutionality of the individual mandate, it failed. 5-4. The Affordable Care Act, President Obama's signature achievement, was dead on arrival. In that moment, a political earthquake was triggered, one that the public wouldn't feel for months. The 5 conservative-leaning justices, including the Chief Justice John Roberts, had voted to strike down the core of the law. The 4 liberal-leaning justices were in the minority, their dissents already being mentally drafted. Had that initial vote held, the news would have been cataclysmic. 20 million people, who were projected to gain insurance, would have that hope extinguished. The entire American healthcare system, which had been reorienting itself for 2 years around this massive law, would have been thrown into utter chaos. It would have been a political victory for one side, and a devastating blow for the other, further cementing the Supreme Court in the public's mind as just another political body, dressed up in black robes. And this is where the story takes a turn that Hollywood screenwriters would reject as being too unbelievable. This is the story of one man, the man in the middle, Chief Justice John Roberts. He had voted with his conservative colleagues to strike down the law, but the Chief Justice has a unique role. He is not just a judge. He is the steward of the court's reputation. He is the guardian of its legitimacy. And as the weeks ticked by, Roberts began to have second thoughts. He saw the storm that was coming. He saw his court being ripped apart by the same partisan winds that were tearing the country apart. He was reportedly deeply concerned about the perception that the court was just an extension of partisan politics. So he started looking for an out, an escape hatch, a way to uphold the law without endorsing the government's sweeping argument about the Commerce Clause. He didn't want to set a precedent that Congress could force citizens to buy any product it wanted. But he also didn't want to be the Chief Justice who presided over a 5-4 decision that invalidated a president's landmark legislation along purely ideological lines. He went back to the government's briefs. He reread the arguments. And there it was, that secondary argument, the afterthought. the one the administration's own lawyer barely wanted to talk about, the power to tax. And John Roberts began to perform one of the most audacious legal maneuvers in modern Supreme Court history. He began to switch his vote, not by joining the liberals on their reasoning but by writing his own. He started drafting a new majority opinion. In this version, he agreed with the conservatives that the individual mandate was not a constitutional use of the Commerce Clause. Congress could not force you to buy health insurance. That part of the conservative argument won, but he then pivoted. He argued that while the mandate couldn't be a command, it could be a choice. The choice was this: either you buy health insurance, or you pay a penalty to the IRS when you file your taxes. And a financial penalty collected by the IRS for choosing not to do something, well, that looks an awful lot like a tax. And under the Constitution, Congress's power to lay and collect taxes is incredibly broad. It's one of its most fundamental powers. Roberts reasoned that it didn't matter what Congress called it. They called it a penalty, but it functioned as a tax. It was a tax on the choice of being uninsured. And as a tax, it was perfectly constitutional. It was an act of judicial jujitsu. He used the conservatives' own principles against them, finding a way to save the law on grounds that its own supporters had downplayed. He was building a bridge, not to the other side's legal argument but to their result. He was going to join the 4 liberal justices to create a new 5-4 majority, but it would be a majority built on his logic alone. On June 28, 2012, the world held its breath. News reporters stationed on the steps of the Supreme Court were handed the printed decision. The initial reports were chaotic. CNN and Fox News famously got it wrong, initially reporting that the mandate had been struck down because they were reading the first part of Roberts' opinion where he agreed with the conservatives on the Commerce Clause. But then as they read deeper, the truth emerged. The Chief Justice had saved the law. He had single-handedly rewritten the ending. The reaction was immediate and visceral. The law's supporters breathed a massive collective sigh of relief, albeit a confused one. They had won, but not in the way they expected. The law's opponents, especially conservatives, were apoplectic. They were stunned, and they were furious. They felt a profound sense of betrayal. John Roberts had been appointed by a Republican president, George W. Bush. He was supposed to be one of them. To them, this was not an act of judicial prudence. It was a political betrayal of the highest order. The man they thought was their anchor had become their executioner. But the drama wasn't over. Lost in the headlines about the individual mandate was a second, equally monumental part of the decision. Because while John Roberts had saved the ACA with one hand, he crippled it with the other. The law also included a massive expansion of Medicaid, the government health insurance program for the poor. The idea was to cover the poorest Americans, those who couldn't afford insurance even on the new marketplaces. The federal government would pay for almost all of it, but states had to agree to expand their programs. And here was the catch. If a state refused to expand its Medicaid program, the ACA said the federal government could withhold all of its existing Medicaid funding, billions and billions of dollars. It was a threat, a powerful incentive, basically an offer you couldn't refuse. And Chief Justice Roberts said, no. He argued that this wasn't an incentive, it was coercion. It was a gun to the head of the states. He wrote that the federal government couldn't force states to accept a new program by threatening to destroy their old one. So, he struck down the enforcement mechanism. He made the Medicaid expansion truly optional. States could choose to expand and the federal government would pay for it. Or they could choose not to and nothing would happen. They'd just keep their old, smaller Medicaid programs. At the time, this seemed like a secondary issue. The mandate was saved. The law would live. But this decision, this single stroke of the pen, would prove to be just as consequential. It cleaved the country in two. It drew a new map of healthcare in America. On one side were the states, mostly blue, that said, yes, we'll take the federal money and expand Medicaid. On the other side were the states, mostly red, that said, no, we refuse. And in that refusal, a giant tragic gap was created. A gap that swallowed millions of people. These were the very people the law was most intended to help. They were adults who were too poor to qualify for subsidies on the new ACA marketplaces. But because their state had refused to expand Medicaid, they weren't poor enough to qualify for their state's existing, bare-bones Medicaid program. They were left with nothing. No options. No coverage. Trapped in a new healthcare no-man's land created by a Supreme Court decision that both saved and gutted the law in the very same breath. The celebration in the White House was real, but it was premature. The fight for the soul of American healthcare was far from over. In fact, it was just getting started. The Supreme Court had spoken. The Affordable Care Act was technically constitutional, but the victory was a Pyrrhic one, because in that same ruling, Chief Justice John Roberts handed a weapon to the law's opponents that would prove to be devastating. The core of the decision rested on the idea that the individual mandate wasn't a command to buy insurance, but a tax on those who didn't. Congress can tax, so the law stands. But in a crucial second part of the ruling, the court addressed the Medicaid expansion. The original law required states to expand their Medicaid programs to cover everyone up to 138% of the federal poverty line. If they refused, the federal government could withhold all of their existing Medicaid funding. The court said this was unconstitutionally coercive, a gun to the head, as they put it. So they changed it. They made the Medicaid expansion optional. And with that one change, the entire foundation of the law was fractured. The ACA was designed as a three-legged stool. First, regulations to stop insurance companies from denying coverage for pre-existing conditions. Second, the individual mandate to make sure healthy people got into the pool to balance out the costs. And third, subsidies and Medicaid expansion to make sure everyone could actually afford the coverage they were now required to have. The Supreme Court had just sawed off half of that third leg. What followed was a slow-motion catastrophe, a political battle fought state by state that left millions of the poorest, most vulnerable Americans stranded. You see, the law was written with the assumption that everyone would get help. If your income was between 100 and 400% of the poverty line, you'd get subsidies to buy a private plan on the new health insurance marketplaces. If your income was below that, you were supposed to be covered by the newly expanded Medicaid program. But now, states could refuse to expand Medicaid. And in the hyper-partisan atmosphere of the 2010s, nearly half the states did just that. This created a cruel, illogical trap that became known as the coverage gap. Imagine you live in a state that rejected the expansion. If you're a single parent making, say, $12,000 a year, you are living deep in poverty. But under the rules of the ACA, you make too little money to qualify for subsidies on the marketplace. The system assumes you'll be covered by Medicaid, but your state has refused to expand Medicaid, so you don't qualify for that either. You are too poor for help. You are stranded in the gap. You're still subject to the tax penalty for being uninsured, but you have no affordable options to get coverage. Millions of people, childcare workers, cooks, construction workers, home health aides, fell into this void. They were the very people the law was designed to help, now left with nothing, victims of a political war they had no part in. While this tragedy was unfolding in state capitals across the country, the Obama administration was racing towards the next monumental challenge, actually launching the system. The centerpiece of the ACA was the health insurance marketplace, or exchange. The idea was to create a simple online shopping experience like Amazon or Expedia, but for health insurance. You'd go to one website, healthcare.gov, enter your information, and see all the plans available to you, with your subsidy calculated automatically. It was supposed to be simple, transparent, and revolutionary. For 3 years, this was the promise. The deadline was October 1, 2013. And on that day, the promise shattered. The launch of healthcare.gov was one of the most spectacular, high-profile technological failures in modern history. The website, which was supposed to serve hundreds of thousands of people, could barely handle a few hundred. Users were met with cryptic error messages, frozen screens, and a system that simply did not work. For the millions of people who had waited years for the chance to get affordable health insurance, it was a moment of profound frustration and disappointment. For the administration, it was a political nightmare. The president's signature achievement was a laughingstock. The media had a field day. Opponents of the law declared it dead on arrival, proof that government was inherently incompetent. The problem was a toxic cocktail of bureaucratic infighting, a lack of clear leadership, and a staggering underestimation of the project's complexity. The back end of the site, the part that had to talk to countless government agencies like the IRS and Homeland Security, plus hundreds of private insurance companies, was a tangled mess of code. It hadn't been properly tested. It was a plane that had been built while it was taxiing down the runway, and on takeoff, the wings fell off. Inside the White House, there was panic. This wasn't just a glitch. It was an existential threat to the entire law. If people couldn't sign up, the insurance markets would collapse. The whole project would fail. In a desperate, last-ditch effort, the administration launched what became known as the tech surge. They secretly flew in a team of Silicon Valley's best and brightest, engineers and managers from Google, Facebook, and Twitter. They set up a war room, sleeping on cots fueled by pizza and caffeine, working 20-hour days to fix the broken website. They described the original code as a tangled hairball that had to be painstakingly unwound and rebuilt, line by line, all while the site was live and under the intense scrutiny of the entire world. Slowly, miraculously, they fixed it. By December, the website was stable. The error messages disappeared, and people started signing up. First by the thousands, then by the hundreds of thousands, and finally by the millions. By the end of the first open enrollment period, over 8 million people had signed up for coverage through the marketplaces, a number that far exceeded the revised pessimistic predictions. The ACA had survived its near-death experience, but the political war never stopped. It was a constant, grinding siege. Opponents in Congress voted to repeal the law more than 50 times. They held hearings, launched investigations, and did everything in their power to starve the law of the funding it needed to be implemented properly. This political sabotage had real consequences. It created uncertainty for insurers, causing some to pull out of the marketplaces and driving up premiums for everyone else. It fueled a relentless disinformation campaign that left many Americans confused about what the law actually did. The two most potent symbols of this public relations battle were a broken promise and a hated mandate. The promise was President Obama's oft-repeated line: "If you like your healthcare plan, you can keep it." But for a few million people on the individual market, this turned out not to be true. Their old bare-bones plans didn't meet the new minimum standards required by the ACA, like coverage for maternity care or prescription drugs. So they received cancellation notices. Politically, it was a disaster. It made the president look dishonest and fed the narrative that the government was intruding into people's personal healthcare decisions. And then there was the individual mandate. The requirement to have health insurance or pay a penalty was by far the most unpopular part of the law. To many Americans, it was the ultimate symbol of government overreach, a direct order from Washington to buy a private product. Economists argued it was essential. Without it, only sick people would buy insurance, causing premiums to skyrocket in a death spiral. But that was a complex economic argument. The feeling of being forced to do something was a simple, powerful, and deeply resonant political grievance. The ACA had survived the Supreme Court. It had survived a catastrophic launch. It was enrolling millions of people and dramatically reducing the uninsured rate. But it was wounded. It was limping. The coverage gap left millions behind. The political opposition was relentless and growing more entrenched. And the public remained deeply, bitterly divided. The law was on the books, but its future was anything but secure. A new political storm was gathering, and in the 2016 presidential election, the promise to repeal and replace Obamacare would become a rallying cry that would once again place the entire American healthcare system on a collision course with history. That rallying cry wasn't just campaign rhetoric. It was a mandate. With the election of Donald Trump, the Republican Party achieved something it hadn't had since the 1920s: control of the White House, the Senate, and the House of Representatives. For the first time since the ACA was signed into law, its opponents had the political power to dismantle it piece by piece. The promise of repeal and replace was no longer a hypothetical. It was item number one on the legislative agenda. The stage was set for one of the most dramatic and consequential political battles in modern American history. The initial assumption was that this would be a swift victory. After years of voting symbolically to repeal the law, this was their chance to do it for real. But the reality of governing proved to be infinitely more complex than the simplicity of campaigning. The moment they sat down to write the replacement, the Republican Party discovered it was deeply, fundamentally divided on what healthcare in America should actually look like. Think of it as three distinct factions all under one roof, all wanting to renovate the same house but with completely different blueprints. First, you had the staunch conservatives embodied by the House Freedom Caucus. For them, the leading replacement bill, the American Health Care Act or AHCA, was nothing more than Obamacare light. It kept the subsidy structure just in the form of tax credits, kept protections just watered-down ones. They wanted a full demolition, a return to a pure free market system with minimal government intervention. They believed the problem with the ACA wasn't its execution, but its entire premise. Then you had the party's moderates. Many of them represented states, even red states, that had expanded Medicaid under the ACA. They saw firsthand how millions of their constituents, many of them low-income working-class voters, now depended on that coverage. They looked at the proposals to roll back Medicaid expansion and saw not just a policy change, but a potential human and political catastrophe. They were staring down the barrel of town hall meetings filled with angry voters who were about to lose their health care, and they were terrified. And finally, you had the party leadership trying desperately to bridge this ideological canyon. They were trying to write a bill that was conservative enough to please the Freedom Caucus, but compassionate enough to not alienate the moderates and spark a massive public backlash. It was a political tightrope walk over a chasm, and with every step, the rope swayed more violently. Into this volatile mix dropped a bombshell: the CBO score. The Congressional Budget Office, or CBO, is the nonpartisan scorekeeper of Congress. Its job is to analyze legislation and estimate its impact on the federal budget and the country. When the CBO analyzed the AHCA, its report was staggering. The initial version it projected would lead to 24 million fewer people having health insurance within a decade. 24 million. That number was a political anchor. It gave Democrats a powerful weapon, and it gave Republican moderates a concrete reason for their fears. No matter how they tweaked the bill, the CBO score remained grim. 23 million uninsured, then 22 million. The numbers haunted the debate, a constant reminder of the real-world consequences of their decisions. And the public backlash they feared? It materialized with a vengeance. Activist groups, many of which had formed to defend the ACA, organized with incredible efficiency. Congressional phone lines were jammed. Town hall meetings became televised spectacles of raw emotion, with constituents confronting their representatives, telling stories of how the ACA had saved them from bankruptcy or allowed them to get treatment for a child's cancer. The narrative shifted. This was no longer an abstract debate about government overreach. It was about families, about life and death. The individual mandate had been unpopular, but the prospect of losing coverage for pre-existing conditions was existentially terrifying to millions. After a bruising fight, the House narrowly passed its version of the bill, sending it to the Senate, where the margins were even thinner. The Senate, by its nature, is a more deliberative, and often more moderate, body. The internal divisions that had fractured the House were even more pronounced. Multiple attempts to craft a bill that could get 50 votes failed. The leadership grew desperate. Finally, in a last-ditch effort, they unveiled what became known as the skinny repeal. The Healthcare Freedom Act wasn't a replacement plan at all. It was a legislative Hail Mary. It would repeal the individual and employer mandates and make a few other changes, but it would leave most of the ACA's structure intact. The strategy wasn't to make it law. It was to pass something, anything, just to get the bill to a conference committee with the House, where they could try to hammer out a final compromise behind closed doors. Everything came down to a single dramatic late-night vote in July of 2017. The chamber was electric with tension. Vice President Mike Pence was presiding, ready to cast a tie-breaking vote. The vote was proceeding, and the count was tied 49 to 50 against. One senator had yet to vote, John McCain of Arizona. Freshly diagnosed with aggressive brain cancer, he had flown back to Washington specifically for this debate. He walked to the center of the chamber, spoke with the party leaders, and then, as the world watched, he faced the clerk, held up his hand, and gave a firm, decisive thumbs down. A gasp echoed through the Senate. The skinny repeal was dead. The 7-year quest to repeal and replace the Affordable Care Act had failed on the floor of the United States Senate. But the failure to pass a legislative repeal did not mean the fight was over. It simply shifted the battlefield. The Trump administration immediately began using its executive power to weaken the law from within. First, it cut off the cost-sharing reduction, or CSR, payments. These were federal payments made directly to insurance companies to help them reduce out-of-pocket costs for low-income customers. The administration argued the payments were illegal without a specific appropriation from Congress. The result? Insurers, no longer receiving the payments, jacked up premiums on the ACA marketplaces to cover their losses, making coverage more expensive for millions who didn't qualify for subsidies. Next, the administration expanded the availability of short-term, limited-duration health plans. These plans were originally intended as temporary stopgap coverage, but new rules allowed them to be sold for up to a year and be renewed. Because these plans were not regulated by the ACA, they were often cheaper, but they came with a catch. They didn't have to cover essential health benefits, could have annual or lifetime caps on coverage, and most critically, could deny coverage to people with pre-existing conditions. Critics labeled them junk plans, a parallel insurance market that siphoned healthy people away from the ACA marketplaces, further destabilizing them. And then came the biggest blow of all, delivered not through executive action, but through a completely different piece of legislation. In late 2017, Congress passed a massive tax reform bill. Buried deep inside was a provision that didn't repeal the ACA's individual mandate, but instead, reduced the tax penalty for not having insurance to $0. Legally, the mandate was still on the books, but practically it was gone. The central pillar of the ACA's three-legged stool, the mechanism designed to compel healthy people into the insurance pool, had been effectively dismantled without a single vote on a healthcare bill. This action opened a new, even more dangerous front in the war over the ACA. The courts, a coalition of Republican-led states, led by Texas, filed a lawsuit arguing that since the Supreme Court had previously upheld the mandate as a tax, and the tax was now zero, the mandate was no longer constitutional. And they argued because the mandate was so central to the law, the entire Affordable Care Act must therefore be struck down. The entire law, Medicaid expansion, pre-existing condition protections, young adults on their parents' plans, everything, was once again facing an existential threat, this time not from Congress, but from the judicial system. As the country headed towards the end of the decade, the legislative battles had quieted, but the foundational questions of American healthcare were as unsettled as ever. The system had survived a near-death experience, but it was battered and bruised, and a new, far more radical set of ideas was beginning to emerge from the political left, promising not to just fix the system, but to replace it entirely. The central question, the one that had been lurking in the shadows of American politics for 100 years, was finally out in the open. Is healthcare a commodity to be bought and sold in a marketplace? Or is it a fundamental human right that a society provides to all its citizens, like education or public safety? The banner under which this question marched was Medicare for All. And while the name was familiar, the idea was revolutionary for the United States. It proposed taking the basic framework of Medicare, the government-funded program for seniors, and expanding it to cover every single person in the country, from cradle to grave. This wasn't another tweak. This wasn't another patch on the existing patchwork quilt. This was a proposal to tear the whole thing down to the studs and build something entirely new. At its core, Medicare for All is what's known as a single-payer system. To understand that, you have to realize that right now we have a multi-payer system. Your employer's insurance company is a payer. The ACA marketplace insurer is a payer. Medicaid is a payer. Medicare is a payer. The VA is a payer. We have thousands of different payers, all with their own rules, their own networks, their own paperwork, and their own profit motives. A single-payer system gets rid of all of that. There would be only one payer for all essential healthcare services. The federal government, funded by taxes. The argument for this is, on its face, incredibly compelling. Imagine a world with no premiums, no deductibles, no copays, and no out-of-network charges. Imagine never having to worry about losing your health insurance if you lose your job. Imagine doctors and hospitals sending all their bills to one place, dramatically cutting down on the billions of dollars wasted every year on administrative complexity and billing. Proponents argue that by creating one massive negotiating bloc, the entire United States population, the government could force drug companies and hospitals to lower their prices, something no single insurance company has the leverage to do effectively. It would be a system based on health needs, not on ability to pay. It's a vision of simplicity and security in a system that has become defined by complexity and anxiety. But to build that world, you would have to dismantle the one we have now. And the argument against Medicare for All is just as profound. First, the sheer disruption would be astronomical. The private health insurance industry, which employs hundreds of thousands of people and represents a massive chunk of the U.S. economy, would be effectively eliminated. Second is the cost. While proponents argue that the total amount our country spends on healthcare would go down, the amount we pay in taxes would go way, way up. It would require the largest tax increase in American history, fundamentally reordering the nation's finances. Opponents paint a picture of government bureaucracy run amok, of long wait times for procedures as seen in some other countries, and of stifled innovation as the profit motive for developing new drugs and technologies is reduced. It's a vision of government overreach, of trading one set of problems for another, potentially worse set. This clash of visions ignited the political landscape. For the first time in generations, a major political party had a significant faction arguing not just for universal coverage, but for a complete government takeover of health insurance. In response, a more moderate proposal gained traction: the public option. The idea here wasn't to replace private insurance, but to compete with it. The government would create its own insurance plan, a public option, that anyone could buy into. The theory is that this government plan, not needing to make a profit, could offer lower premiums and better coverage, forcing private insurance companies to lower their own prices and improve their services to stay competitive. It was pitched as the best of both worlds, a way to increase coverage and lower costs without the massive disruption of a full single-payer system. And so the battle lines for the future were drawn. On one side, a revolutionary call for a single-payer system. On the other, a defense of the private market, often coupled with calls for more deregulation, price transparency, and consumer-driven plans like health savings accounts. And in the middle, the evolutionary approach of the public option, an attempt to build upon the ACA and nudge the system toward universal coverage. And that is where we are now, standing at a crossroads, looking back on a century of choices that created the most expensive, complex, and paradoxical healthcare system in the world. A system born from a wage freeze in World War II. A system that provides some of the best medical care on the planet, but leaves millions in debt or without access. A system that has been the subject of epic political battles in nearly every generation, from Truman to Johnson, from Clinton to Obama. What we've seen on this journey is that our healthcare system was never designed. It wasn't the product of a grand vision. It was assembled piece by piece over 100 years, with each piece being a political compromise, a historical accident, or a reaction to a crisis. It's a story of unintended consequences. A tax break meant to help factories during the war accidentally created our employer-based insurance system. A program designed to help the elderly accidentally solidified the hospital as the center of the medical universe. A law intended to make healthcare more affordable ended up becoming a political lightning rod that nearly tore the system apart. Each step of the way, the debate has always been about more than just healthcare. It's been about our deepest held beliefs. What do we owe one another as citizens? What is the proper role of government in our lives? What is the balance between individual liberty and collective responsibility? The answers to those questions are not simple, and they are not settled. The history of American healthcare is the history of a nation constantly arguing with itself about who it wants to be. And that argument is not over. The next chapter has yet to be written. The choices that will be made in the coming years, whether to defend the current system, to build upon it with something like a public option, or to replace it entirely with a single-payer program, will shape the health, the finances, and the lives of every single American for generations to come. Understanding this history is not just an academic exercise. It is the most powerful tool you have. Because now you know that the system we have is not inevitable. It's not the only way. It was built by people making choices at specific moments in time. And because it was built, it can be changed. The immense, confusing, and often frustrating system that dictates so much of our lives is not a force of nature. It is a product of our democracy. And in a democracy, the ultimate power to shape the future, to decide which path we take at this crossroads, belongs to you.